Hello, my name is Dr. Charles Weaver. I am a medical oncologist and the founder and publisher of Cancer Connect. I want to thank you for joining us today for a live chat with Dr. Abu-Rustum, Dr. Temple, and Joanne Kelvin from Memorial Sloan-Kettering Cancer Center on cancer and fertility options for women. Joanne Kelvin is a clinical nurse specialist and leads Memorial Sloan-Kettering's Cancer and Fertility Program. She will provide an overview of how cancer treatment can affect fertility in women and will discuss options that may be taken prior to treatment to preserve a woman's ability to have a biologic child, such as egg and embryo freezing. She will also discuss alternative options available post-treatment to help build a family, such as use of donor eggs and adoption. Dr. Abu-Rustum is the director of minimally invasive surgery for the Gynecologic service at Memorial Sloan-Kettering. His expertise includes minimally invasive and general gynecologic surgery for cancers of the ovary, uterus, and cervix. Dr. Abu-Rustum will discuss fertility-preserving techniques available to women who are newly diagnosed with an early-stage gynecologic cancer and are considering their treatment options. Dr. Temple is a surgical oncologist in the colorectal service at Memorial Sloan-Kettering. An expert in the treatment of colon, rectal, and anal cancer, she has a special interest in preserving bowel, bladder, and sexual function, as well as quality of life after colorectal cancer surgery. She also oversees Memorial Sloan-Kettering's colorectal survivorship clinic. Dr. Temple will present information on standard and investigational treatment options available to preserve fertility in women newly diagnosed with colon or rectal cancer. During today's program, you'll have the opportunity to submit questions. Just type in your question in the space provided below on the screen. The experts will answer as many questions as possible in the time allotted, following their presentations. I will now turn the presentation over to Joanne Kelvin, Dr. Abu-Rustum, and Dr. Temple. Thank you.
Welcome to this webinar on cancer and fertility. My name is Joanne Kelvin. I'm a clinical nurse specialist in our survivorship program. Advances in cancer treatment have led to significant improvements in survival. However, many of these treatments have the potential to impair fertility. Tonight, I will be discussing the options that patients have to preserve fertility before treatment begins, as well as those to build a family after treatment is completed. First, it's important to understand how your treatment may have affected you. Depending on the specific surgery you may have had, removal of reproductive structures may have an impact on your supply of eggs or on your ability to conceive or carry a pregnancy. The pituitary gland in the brain secretes hormones that control menstruation and ovulation. If the gland is damaged from surgery or cranial irradiation, hormone levels can be affected, which may impair fertility. The ovaries contain all our eggs, each in a tiny sac called a follicle. Girls are born with about 1 million eggs, and we lose these gradually as we age. Certain chemotherapies, as well as radiation exposure of the ovaries, may destroy eggs, potentially leading to infertility and the development of early menopause. High doses of radiation to an area that includes the uterus can cause fibrosis or scarring. This can make it difficult for an embryo to implant, and if a woman does become pregnant, she may be at risk for miscarriage or early labor. Now, of course, many women will have no problems with fertility after their treatment, but it's impossible to predict with certainty who will be affected. If you have not yet begun your treatment, there may be options to preserve fertility before treatment begins. Embryo or egg freezing is one consideration. The process begins with daily hormone injections for about 10 days to stimulate your ovaries so that a group of eggs will mature. You can see here about 5 large follicles in the ovary, each with a single mature egg. Once the eggs have fully matured, eggs are retrieved during an outpatient procedure performed with anesthesia so that women are asleep during this. An ultrasound probe is placed in the vagina so the ovaries can be seen. A thin needle is passed through the wall of the vagina up to the ovary and punctures each of the follicles to withdraw the eggs. The whole process takes about 15 minutes. The eggs are brought into a laboratory where each egg is fertilized with sperm to create an embryo. This is called in vitro fertilization, or IVF. The embryos are frozen and stored in case you need them later. Alternatively, you can choose to have unfertilized eggs frozen and stored. These procedures are performed at fertility centers by reproductive endocrinologists. Now, before pursuing embryo or egg freezing, it's important to speak with your doctor to ensure that it's okay to wait the 2 to 3 weeks that this can take, and to be sure that the hormone injections, which will increase estrogen levels, are safe for you. Egg and embryo freezing can be costly, and health insurance does not usually cover this. The cost can run between $15,000 and $18,000. However, there are financial assistance programs available if you meet certain eligibility criteria. For those of you who have completed treatment and are thinking about your options for building a family, a first step is to speak with your oncologist. Ask how long you should wait after treatment. Most patients are recommended to wait at least 1 to 2 years. This allows time for any eggs that may have been damaged by chemotherapy or radiation exposure to be cleared from your body. It gives you time to recover from the effects of treatment before undergoing the stress of pregnancy. And it allows you to pass the period of time during which you may be at risk for an early recurrence or relapse. Another question to ask is if you should be considered a high-risk pregnancy based on the treatment that you've received. If yes, your doctor may recommend that you must see a maternal fetal medicine specialist who will discuss your risks, evaluate the safety of becoming pregnant, and follow you closely throughout the pregnancy. Your success at being able to conceive naturally will depend on many factors. One of these is your ovarian reserve, a term used to describe the number and quality of eggs a woman has at any particular point in time. Ovarian reserve testing is performed by a reproductive endocrinologist. This could be considered if you're unsuccessful in getting pregnant after trying for 3 to 6 months, or if you just want to know your fertility status at some point after treatment. However, we recommend that you wait at least 12 months after treatment is completed to give your ovaries time to return to their optimal function. An ultrasound is performed to visualize the ovaries. Each of the dark spots you see in the ovary is a developing follicle. These large andral follicles are counted. In addition, blood will be drawn to check various hormone levels. Together, these tests help determine your likelihood of success in becoming pregnant. Now, based on your ovarian reserve, your reproductive endocrinologist will outline your options. If you have adequate ovarian reserve, one option, of course, is to attempt pregnancy naturally. If you're not yet ready to start a family, but are at risk for early menopause based on the treatment that you've received, you could consider egg freezing. The process is exactly the same as I described for patients who freeze eggs before treatment. For women with low ovarian reserve, ovarian stimulation with IVF may be considered. Again, the process is exactly the same as I described for patients who do this before treatment. However, instead of freezing all the embryos, 1 or 2 are transferred to the uterus to attempt pregnancy. The rest of the embryos will be stored for future use. Another option, if you're not able to get pregnant naturally, is to use eggs or embryos you froze before treatment. These would be thawed and transferred to your uterus. If you froze eggs, these would of course first have to be fertilized with sperm to create embryos before the transfer. For women who are not able to get pregnant naturally or with IVF and did not freeze eggs or embryos before treatment, there are other options for becoming a parent. One option is to use eggs donated by a healthy young woman to help someone like you. Another option is to use embryos donated by couples who underwent fertility treatment with IVF and now have extra embryos that they would like to donate. Some fertility centers have their own egg or embryo donor programs, or you can obtain these from donor agencies. Donors are screened to evaluate their physical and psychological health and to assess their family health history. The cost of using donor eggs is about $30,000. Using donor embryos is much less. Surrogacy with a gestational carrier is an option for women who are unable to carry a pregnancy. It involves arranging for another woman to carry a pregnancy for you. Embryos are created through IVF using your eggs or donated eggs, fertilized by your partner's sperm or a sperm from a donor. The embryos are then transferred to the uterus of the carrier. The carrier is the birth mother, but has no genetic relationship with the child. Most people find carriers through an agency or a reproductive attorney. Laws related to surrogacy are complicated and vary widely from state to state, so it is essential to work with an attorney who has expertise in this area. Using a carrier is quite expensive, generally ranging from $50,000 to $100,000. Adoption is, of course, another option for building a family, and having a history of cancer does not prevent you from being able to adopt. But you will need to be healthy now and cancer-free for at least 3 to 5 years. It's important to interview various agencies and attorneys to find one that you feel will support you in pursuing adoption. The cost for adoption is about $35,000 when you work with a private agency or attorney. For those of you looking to build a family after cancer treatment, this is just a very brief overview of your options. So where do you go from here? Clearly, you need to research and learn more. I've listed here a few websites you can explore, but there are many more resources based on the specific options you are considering. If you're a patient here at Memorial Sloan-Kettering, you can ask your doctor or nurse for a referral to the fertility nurse specialist to get more information. Speak with your oncologist before you finalize any plan to make sure they have no concerns based on your personal medical situation. For those of you who have completed treatment and may be fertile now, consider scheduling an appointment with a reproductive endocrinologist to evaluate your fertility status. This will help to clarify what options will be feasible for you. Investigate and plan for the financial costs involved, which may be considerable depending on the option you pursue. The legal issues with donor egg, carriers, and adoption can be complex, so you may want to schedule a consultation with a reproductive attorney if considering one of these. If you're not able to get pregnant naturally, the process of building a family can be complicated and can elicit feelings of anger, sadness, and grief. If you're finding that these emotions become overwhelming, if they persist for many weeks, or if they make it difficult for you to take the next steps, professional counseling may be helpful. We know that for some women, the process of building a family after cancer treatment can be complicated and can take persistence and endurance. However, as you walk down this path, keep in mind that many people have passed through before you and have been successful. I hope this information will be helpful as you start on your own journey.
Hello, my name is Nadeem Abu-Rustum. I'm a gynecologic oncologist, and I'm going to cover aspects of fertility-sparing surgery in gynecologic tumors. The 3 most common gynecologic cancers that we treat are cervical cancer, endometrial cancer, and ovarian cancer, and I will review quickly the options for fertility-sparing surgery in each of these tumors. We're going to start with cervical cancer. Now we have guidelines that are nationally accepted to offer fertility-sparing surgery for select young women who have small tumors of the cervix to preserve the uterus, avoid hysterectomy, cure the cancer, and still allow for the ability to carry a child and deliver a healthy term pregnancy. These are usually selected cases based on very small tumors where there's no evidence of cancer outside of the cervix. The smallest tumor that this would be eligible for would be something called a stage 1A1, and that can be treated with a procedure called a conization, where it's basically a large biopsy of the cervix to remove the cancer, get clean edges around the cut edge of the conization, and then the uterus can be preserved. Sometimes we combine the conization with the removal of lymph nodes by a technique called sentinel node mapping, where we inject a dye into the cervix. The dye will guide us to the most important lymph node. That's a colored lymph node seen here. This lymph node is removed by laparoscopy, and then a conization is done. Patients can usually go home the same day, recover for a couple of weeks, and that would be fertility-sparing treatment for the small cervix cancer. If the cancer is a little bit larger, then we would have to do a slightly bigger operation called a trachelectomy, where you actually have to remove the majority of the cervix, sometimes the entire cervix and the surrounding tissue. And that's done for when the stage is slightly higher. This is also accompanied by removal of lymph nodes. And again, we can carry the same procedure now to a higher stage called stage 1B1, where the tumor is bigger in the cervix. And that would be the maximum stage that we would offer fertility-sparing surgery for. Beyond stage 1B1, it's very difficult to preserve the uterus and preserve fertility. But many patients who come in with stage 1 cervix cancer, who are younger than 43, who want to preserve fertility, these procedures can be worked up and offered and can be successful in many patients. This is again a diagram showing you the area where the procedure will be done to remove the cervix and avoid removal of the uterus, tubes, and ovaries. Again, removal of lymph nodes in the pelvis is a very important part of many of these cases, and this is usually done minimally invasive using a sentinel node mapping technique, where you inject a dye into the uterus that will guide you to the most important lymph nodes, so you can remove these lymph nodes and avoid removal of a lot of lymph nodes that can result in leg and foot swelling or lymphedema. Trachelectomy basically is to remove the cervix, preserve the fundus, and these images are going to give you an idea of what's removed. And then we reconstruct the cervix. We put a cerclage. This will help hold the baby during pregnancy, so the mother won't have a miscarriage. This is a permanent suture that stays in, and then the mom delivers by C-section. Again, the uterus is reconstructed back to the top of the vagina. So this was a summary of what can be done for cervix cancer. Moving on to endometrial cancer, this is a little bit different cancer. And again, you can see from this diagram that women are delaying first birth and first childbearing because of change in culture. Women are working more. They're preoccupied with their jobs and education, and they're delaying childbearing. So you can see here that the percentage of women having children later on in life, after 30 and after 35, is increasing with time. So again, as you delay childbearing, you run a higher risk of developing uterine cancer. Of course, obesity is also increasing in our society, and that also is another risk factor for uterine cancer. So when we see somebody with endometrial cancer, we have very strict criteria to select patients that may be candidates for uterine preservation. And it's a very strict list, and I'll go through this list. The tumor has to be the least aggressive type, called the grade 1 endometrioid. That's determined by a pathologist. The diagnosis has to be done at the time of a dilatation and curettage DNC and hysteroscopy, not just an office biopsy, but a full scraping of the uterus. The pathologist has to really review the entire specimen, and it's best to have an expert gynecologic pathologist that will give you the best diagnosis and avoid a misdiagnosis. You have to make sure that the family history is not suggestive of a familial cancer syndrome such as a Lynch syndrome. This is a syndrome where you can have uterus cancer, colon cancer, ovarian cancer, urinary tract cancer. And again, if the patient fits into that syndrome, fertility-sparing surgery is probably not a reasonable option. Of course, we do a pap smear and we check a CA-125 to make sure that the cervix and there's no high risk for metastasis outside of the uterus. And again, it's very important to obtain a pelvic MRI, a magnetic resonance imaging. This is a very important test to make sure there's no invasion of the tumor into the muscle of the uterus, because that would be a contraindication for fertility-sparing surgery. And we always get a consultation with a reproductive endocrinologist and a fertility specialist to make sure the patient has a good potential for reproduction, and then if she's going to go through this fertility-sparing management, that she actually does have a reasonable chance of conceiving in the future. So obtaining an MRI is a standard of care for us. And again, consultation with infertility and reproductive endocrinology is also a standard of care, because you want to make sure that the patient does have good fertility preservation potential before she commences with uterine preservation. Once all these are achieved, then we can attempt uterine preservation. So again, in summary, it has to be a grade 1 endometrioid histology, age less than 43 usually, no muscle invasion by MRI, no obvious metastasis by MRI, no evidence of Lynch syndrome, very strong desire to avoid a hysterectomy, and again, no absolute contraindication to treating the patient with a progestin, because that would be the treatment, either a progestin tablet, injection, or an IUD of progesterone. And again, consultation with infertility specialists to make sure that there is good potential for reproductive function. The treatment with progestin can last sometimes up to 6 or 9 months or sometimes a year. So we want to make sure that the patients have seen the reproductive endocrinologist and they do have a good potential for conceiving. The treatment is usually not surgical. It's usually done by a progesterone medication, either a tablet, an injection, or an IUD placed inside the uterus. And then resampling is done at 3 months, 6 months, 9 months until the pathology clears, and then the patient's allowed to conceive. If there's failure to regress the problem, then hysterectomy is usually considered. Moving on to the third cancer and the last gynecologic cancer that we're going to discuss, these are ovarian tumors, and they fall into 2 categories, something called a borderline tumor or a low malignant potential, and then the obvious invasive ovarian cancer. And clearly, the obvious invasive cancer will be much more difficult to do fertility-preserving surgery. The borderline tumor is much more amenable to fertility preservation. Conservative surgery for ovarian tumors usually removes one side, like one tube and ovary, or just the cyst, and preserves the other side. And then you have the option of freezing eggs or freezing embryo from the preserved ovary, either the contralateral side, or sometimes even if you preserve half of that ovary, you can obtain eggs from the remaining ovary. The surgery options are usually to remove just one tube and ovary or remove the cyst alone, but if you remove the cyst alone, it carries a higher risk of recurrence in that same ovary. If you remove both tubes and ovaries, then of course you would need a donor egg, or if you have eggs or embryos frozen, then they can be placed back into the uterus. In general, for borderline tumors, if there's no obvious metastasis, then you can remove one adnexa, one tube and ovary, preserve the uterus and the other side, and that can be successful in many patients. If you have an invasive cancer, then you have to be very careful with strict criteria to make sure you're not putting the patient at risk. In general, we would offer fertility-sparing surgery for young women who have cancer affecting only one ovary that's absolutely determined to be stage 1 with no obvious spread. Those would be the best candidates for fertility preservation. If you need chemotherapy, it may also affect the remaining ovary, may compromise fertility, but it has been shown in studies that in younger women, even if they receive chemotherapy for certain types of ovarian tumors, fertility can be preserved. So this was a summary of the 3 most common cancers: cervix, uterus, endometrium, and ovarian cancer. And again, today, we have newer technology, and with the help of pathology, radiology, and better imaging, we can preserve fertility in many patients who present with this disease. Thank you very much.
You're probably very nervous right now after just receiving a diagnosis of colorectal cancer and wondering how it's going to affect your fertility. I want you to know that many people after the diagnosis of colorectal cancer and treatment do very well and live full lives. In patients with more advanced disease, people are living longer with good quality of life. My name is Larissa Temple, and I'm a colorectal surgeon at Memorial Sloan-Kettering Cancer Center and a member of our colorectal cancer disease management team. I want to spend the next few minutes talking about the treatment of colorectal cancer, and then I want to spend the rest of our time talking about how colorectal cancer can affect fertility. As most of you know by now, the colon and rectum are a contiguous structure in the abdomen and pelvis. The colon is about 6 feet and the rectum is about 1 foot. The job of the colon is to absorb water, and the rectum holds stool. You can live without your colon and/or your rectum. When people are diagnosed with colorectal cancer, their first reaction is usually to get it out. But it's important to know that the treatment of colorectal cancer usually includes other treatment modalities, such as chemotherapy or radiation. The treatment for colorectal cancers are different and depend upon the size and location of the tumor. You and your doctors will discuss the right treatment strategies for you. All treatments for colorectal cancer can affect fertility in women. As you can see, this is a cross-section of a woman's pelvic anatomy. The tubes and ovaries are here, And the uterus and rectum are very close to one another. The colon and rectum are close to the ovaries, whereas the rectum is close to the uterus. Any treatment for colorectal cancer can affect both the uterus and the ovaries. And for the next several minutes, I'm going to focus on how treatment affects fertility, current fertility options, and novel approaches. Surgery is part of almost everyone's treatment. Surgery can be done through minimally invasive techniques, such as the robot as shown in this slide, or using more traditional methods as shown in this portion of the slide. While the incisions may be smaller and the pain may be less with minimally invasive surgery, either method can cause internal scarring. This scar tissue can affect the alignment of the ovaries and make it difficult for eggs to travel through the fallopian tubes and enter the uterus for fertilization. Chemotherapy may be used before or after surgical treatment. For rectal cancer, we often use chemotherapy before and after surgery, while in colon cancer, we normally use chemotherapy after surgery. Chemotherapy can affect ovarian function, and this is particularly true for women who are slightly older. We often recommend banking eggs prior to starting chemotherapy. Radiation is usually only used in patients with rectal cancer. It's a very important part of therapy. However, it has significant impact on fertility in women. Although the radiation targets the rectal tumor, it also affects other organs in the pelvis, and in particular, the uterus and ovaries. After radiation, most women stop menstruating. Now that we've talked about treatment and fertility, I want to talk about fertility options that are available when we use standard of care for the management of colorectal cancer. With surgery, the options for fertility include natural conception, and if due to scar tissue conception does not occur, IVF is available. For chemotherapy, we recommend pre-treatment consultation with fertility specialists in conjunction with a medical oncologist and consideration for egg or embryo banking. Now, in patients who have rectal cancer and require radiation, we consider ovarian transposition. Using minimally invasive techniques, our gynecologic oncology colleagues like Dr. Abu-Rustum move the ovaries out of the radiation field. The ovaries are moved out of the pelvis with minimally invasive techniques and placed further up in the abdomen. The gynecologic oncology surgeon marks where the ovaries are with a clip so that the radiation oncologist can plan the radiation fields and avoid the ovaries. In this way, the ovaries are not included in the radiation field, and this is helpful because it prevents menopause in premenopausal women. Now, while ovarian function can be preserved with the transposition of ovaries, we still recommend banking of eggs pre-treatment. But more importantly, for women with rectal cancer who've had radiation to the uterus cannot support a pregnancy. In these cases, surrogates are an option, and family members can sometimes be the surrogate. We can now preserve eggs and/or embryos, and women have more options after colorectal cancer therapy for fertility. However, as we've just discussed, for women with rectal cancer and have had radiation to their pelvis, they cannot carry a pregnancy. There are some novel approaches for patients with rectal cancer that may result in less injury to the uterus, and they may become standard in the future. The first of these novel options would be to possibly change the way we deliver radiation. I'm not a radiation oncologist, but the technologies are changing. In the past, we would have these large fields where we gave radiation to the entire field. And now, using more modern technologies and better imaging, we're able to cone down more on the rectal cancer and give less radiation to tissues surrounding the rectal cancer. It may be possible that one day we will be able to give lower doses to the uterus, and so a woman could potentially carry a pregnancy. However, unfortunately, we don't have this technology yet. Another option is to use less radiation, and I'm very proud of our participation in this national randomized trial to address this question of individualizing the use of radiation in women with rectal cancer. And let me give you a bit of the background. As our surgical techniques and chemotherapeutics have improved, it may be that we do not need to use as much radiation as we did in the past. If you go on to clinicaltrials.gov, you'll actually see the schema of this trial. Now, it's a complicated schema, and the purpose is just to show you that it's there on the web. But essentially, this trial randomizes patients to chemotherapy with or without standard radiation. Now, if the outcome of this trial shows that patients do just as well without the radiation compared to patients with the radiation, then we may actually change our treatment paradigm and use significantly less radiation for people with rectal cancer. And if we can avoid radiation to women with rectal cancer, women can potentially carry pregnancies after the treatment of rectal cancer. We've talked about a lot of issues, and I think that after the diagnosis of colorectal cancer, it's important to take a breath. And this is an excellent diagram of the steps that you need to consider if you're concerned about fertility in the context of dealing with a colorectal cancer. First of all, I think it's very important to develop a treatment plan with your medical oncologist. And then it's important to step back and ask yourself how important fertility is to you today, and also how important fertility is to you in the next 5 years. Taking that information, it's important to speak with your medical oncologist and your nurses to discuss the impact of the cancer and its treatment on your fertility. And if you are interested in fertility, making the proper referrals up front can help us provide more options to consider fertility preservation. Now, if you're in the middle of treatment or finished treatment, it's important that you talk to your care team now because there are still options available. So if having children is an important part to you after treatment, it's very important to let your doctors and nurses know as early as possible. We can help you come up with a treatment plan that addresses issues around fertility. And while we design the treatment for your cancer, we are often able to make the right referrals to fertility assessments and treatments without delaying your cancer treatment in any significant way. We have wonderful collaborations with various groups in Manhattan and the tri-state region who are more than happy to be available to facilitate any fertility assessments in an expeditious fashion. We can also make a referral to Joanne Kelvin with our Cancer and Fertility Program to learn more about your options and make referrals to fertility specialists who we work with and discuss your options for financial assistance. I wish you all the luck with your cancer treatment, and I look forward to answering your questions.
Good evening. Thank you for logging in and participating in our webinar tonight. We've received a number of questions from viewers over the past few days, and so the three of us are going to go through these questions and try to answer them as best we can. So the first question, I am 37 and have been diagnosed with rectal cancer Duke C. I am single, but have always thought that I would have kids someday soon. I was initially told that I could harvest my eggs and then start the chemotherapy and radiation. My oncologist has inferred that if I delay by going through this, the cancer may become untreatable. I know there are other options like adoption, but I'm really confused and scared about delaying. And this is from someone in Harvest, Alabama. So in general, with many types of rectal cancer, depending on when your treatment is supposed to start, delaying for egg freezing can often be safe. The process takes about 2 to 3 weeks, and you really need to check with your oncologist about whether that time frame is going to be safe for you. In fact, if you are going to get radiation, sometimes the treatment planning itself can take a couple of weeks, and so that you're not actually delaying the treatment. So, you know, I would really go back to your oncologist and clarify exactly how much time you have, and then, you know, have a greater discussion with him about the importance of this to you.
So thanks again for joining us. I have a question from a 34-year-old female who has a BRCA2 mutation, who is a 4-year survivor from breast DCIS, ductal carcinoma in situ. And the question is, am I at higher risk for recurrence if I get pregnant to give some reassurance to that. Most of the data that we have on BRCA patients is really retrospective, meaning we've never really studied this prospectively, and these data are confounded by bias of healthy younger women. But in general, if it's just DCIS, we don't have any evidence that there will be harm in pregnancy, and we would say in general, given the facts that were presented in this question, it would be safe to proceed with pregnancy.
So my first question is from Danville, Virginia. And the question is, how long after treatment with 5-FU should you wait to get pregnant? And I think that's a very good question. And I think it's important to know, while I'm not a medical oncologist, the medical oncologists always tell me that 5-FU is a fairly safe drug and has in fact been used while people are pregnant. That said, we feel, and our medical oncologists feel, that it's important to wait after treatment for two reasons. First of all, we want to make sure that that you've settled out after your therapy. We generally like to scan and make sure that there's no evidence of disease, and just make sure you've sort of recovered from the chemotherapy. Our medical oncologists, and Joanne will concur, we generally like to wait about a year after the completion of chemotherapy before we encourage people to attempt conception. And so that's generally what we recommend. Joanne, do you have anything?
No, I mean, sometimes your oncologist may want to give you an extra year. The first year is really to prevent you from getting pregnant with any eggs that have been exposed to chemotherapy, but you may be recommended to wait an additional year to allow for scanning that would not be able to be done if you were pregnant, and kind of get you to that 2-year mark after treatment to make sure there's no sign of recurrence.
And if I could just interject one thing, generally if you're contemplating getting pregnant, it's really important to let your medical or surgeon know, because what we tend to like to do clinically is we like to get scans done just so as close to conception as possible, because during that 9 months of carrying a baby, we really can't do the kinds of investigations that we typically do. So if you are considering conceiving, it's important to let the doctors know so that we can actually make sure we get all the tests done before you conceive, so that we have all the information and we feel comfortable watching you without those tests during that 9-month period.
So my next question is from Toledo, Washington. And the question is whether or not it's safe to undergo stimulation and egg retrieval for embryo freezing before treatment for breast cancer. So one of the concerns with breast cancer is that some types of breast cancer are positive for estrogen receptors. What this means is that the cells can be stimulated to grow and divide if they're exposed to estrogen. And during the stimulation process, while you're taking the hormone injections, the estrogen levels will go quite high. It's a bit controversial as to whether or not women should undergo this. There's been no rigorous research to say for sure whether it's safe or not. But as more and more women are doing this with breast cancer, there's been no anecdotal evidence that people are at greater risk for their disease coming back. Some people feel that compared to a lifetime of estrogen exposure, the elevation that women experience over 3 weeks is probably insignificant. But nevertheless, because people are concerned, anyone with breast cancer is generally recommended to take a pill called letrozole during stimulation and for about 1 week afterwards. That would be given by the reproductive endocrinologist. And that drug lowers the estrogen levels significantly and makes us all feel more comfortable about the process.
I have a question that's also on breast cancer. This is from a young patient. She's 31 from Los Angeles, California. Stage 3 breast cancer, locally advanced breast cancer. Had mastectomy and is scheduled for radiation and chemotherapy. And the question is, what are my options for having children later? She's 31. So I think it depends on the estrogen receptor status of the tumor. So if the breast cancer is estrogen receptor positive, most medical oncologists are going to prescribe tamoxifen, and I think a standard of care now is to actually use it for up to 10 years. So, and we don't have good data to say that stopping after 2 to 3 years and getting pregnant is safe. So in general, if the tumor is estrogen receptor positive, locally advanced breast cancer, node positive, probably tamoxifen is going to be recommended for 10 years, and then after that, consider a pregnancy. If the tumor is estrogen receptor negative, then usually we wait 2 to 3 years because most of the recurrences happen the first 2 years. So if in 2 to 3 years there's no evidence of disease, the tumor is estrogen receptor negative, then pregnancy can be attempted.
So my next question is from Everett, Massachusetts, and it's from a woman who's a colon cancer survivor and had chemotherapy. She's now pregnant, and she's worried that the drugs that she had for treatment will somehow impact her baby. The treatment finished 14 months ago, and her gynecologist says that these drugs won't affect her fertility, but she wants our opinion. Well, first of all, I'd like to say congratulations. You've had a really rough year with diagnosis and treatment, and now 14 months later you're pregnant, and I think that's fantastic. I want to reassure you that, just as we talked about before, you conceived 14 months after therapy, and so as a result we feel very comfortable with the conception and the risk, there is data that suggests, that compares women who, all patients, men and women, who have been treated for cancer and who are more than a year from their treatment, and compares the birth defect rate to the regular population. And it's important for you to know that the birth defect rate is the same in patients who've had chemotherapy 12 months ago versus people who have not had chemotherapy. So the concern about birth defects is always there, but it's really no higher than if you hadn't had the chemotherapy. And I think it's a really wonderful story. The other thing I think that you should talk with your gynecologist about is 2 things. It's very important that you continue to do the routine work checkups with your gynecologist. If there's any concerns, speaking about being a high-risk pregnancy is always a possibility. But it's also important that a woman who's had colorectal cancer talk about the delivery with their obstetrician. In women with colon cancer, the vaginal deliveries will probably have no effect on long-term continence. But if you've been treated for rectal cancer or a sigmoid cancer, there's a possibility that with a vaginal delivery there's an increased risk of changes in your continence. So I think it's important to talk with your obstetrician about whether or not you should be considered for a C-section. But again, it's a personal decision, and it should be made in conjunction with your obstetrician.
This next question is from Boulder, Colorado. How long can an embryo or egg be frozen? So there is no restriction in this country on how long eggs and embryos can be stored. And there's no central database that tracks how long they've been stored. But there have been isolated published reports. In terms of embryo freezing, the oldest embryo that I could find that was used and resulted in a live birth had been stored for 24 years, which is very reassuring. Now, egg freezing is a much newer technology, and so the oldest reported frozen egg that has resulted in a live birth was 12 years. And that's really before they developed some of the technology that's used now to freeze eggs. So it's anticipated that it'll probably be as long as embryos.
Next question is from Manchester. This patient with BRCA gene who elected to have her ovaries removed. And the question is, best way to still be able to have a biologic child. So if the ovaries were not stimulated before and eggs were retrieved and frozen, or no embryos frozen, and now the ovaries are already removed, there is no option for having a biologic child. You would need a donor egg. If the uterus is still in place, a donor egg with a sperm and embryo can be made and placed in the uterus, and the person can get pregnant. But if the ovaries are already out and there's no stored eggs or stored embryos, it's not possible to have a biologic child.
So the next question is from Houston, Texas, and it's a question about ovarian transposition. And their question is, when is ovarian transposition recommended instead of just removing an ovary and freezing it? I think when we treat rectal cancer, as I said in my talk, we generally do ovarian transposition. And the advantage of ovarian transposition is it's a small surgical procedure, and by moving the ovaries out of the pelvis, women can maintain their hormonal function. In general, though, if a woman wants to consider conception after treatment, we do recommend that in addition to ovarian transposition that they consider banking either ovaries or embryos. In terms of removing ovaries and freezing it, I think I'll ask Joanne to comment on it. To my understanding, it's much more sort of experimental, but I'll get Joanne to comment on that.
So ovarian tissue freezing is an investigational option, and in post-pubertal women, there have been about 20 babies born from the reimplantation of ovarian tissue after treatment's completed, and some patients have been kind of cleared to attempt pregnancy. But that's only 20 babies worldwide, and so freezing eggs or embryos is much more likely to be successful. So definitely one priority would be to do that before treatment. And then moving the ovaries, although it may not preserve enough eggs to be able to get pregnant from those eggs, it certainly can, in many women, especially if they're younger, preserve enough eggs so that there's good ovarian function with hormone production. So you would never really go for an investigational option that's less successful when there's an option that's kind of standard and has much higher success rates.
Next question is also on BRCA1. This is from a recent breast cancer survivor from Cortland, New York. The question is, BRCA1 carrier. I'm planning to have my ovaries removed later and wondering about the potential and concerns of carrying a pregnancy in the future with the remaining uterus. So in general, ovaries can be stimulated, eggs removed and frozen, or embryos made frozen, and the uterus can remain in place, and then the embryo can be placed back in the uterus. You don't need to have ovaries to carry a baby in the uterus. What potentially can complicate answering this question is the status of the breast cancer. So, as we had mentioned in the previous discussion, it depends whether or not you're going to need tamoxifen, because many times tamoxifen now is being prescribed for more than 5 years, up to 10 years, and also depends whether it's a locally contained breast cancer, early breast cancer, or is it advanced lymph node positive. In general, if it's estrogen receptor negative, lymph node positive, usually a waiting period of 2 to 3 years before attempting a pregnancy. Also, stimulating the ovaries, as Joanne mentioned, will result in a small surge of estrogen. Most oncologists feel that it's reasonable, at least in gynecology, to go through that for the objective of retrieving the eggs. But again, the question of the breast cancer in this setting has to be resolved. In general, eggs can probably be retrieved and potentially a pregnancy achieved.
So my last question is from a woman in South Haven, Mississippi, and she's recently been diagnosed with colorectal cancer and is scheduled for radiation therapy and chemotherapy followed by surgery. And she asks what are the changes that radiation or chemotherapy will occur and how will it affect her fertility, and she's 28. I hope that in my talk I outlined the majority of the possible changes that can happen. The chemotherapy can affect the ability of the ovary to function, although by being 28, we've done a study here and looked at ovarian function in women before and after 40, and we've actually found that women who are menstruating generally resume menstruation afterwards on chemotherapy alone. The bigger concern, of course, is the effect of radiation. The radiation can result in the ovaries losing their function. And so I think that this is an excellent example of someone where you really should speak with your medical and radiation oncologist and talk about the various options, including banking and potentially transposing ovaries. But I hope that my talks outlined these and have answered your question more thoroughly.
So my next question is from Florence, South Carolina. I have read a little bit about fertility protective drugs. Is this still early in the research process or something that might be available soon? So there is one drug that is approved for other uses, but is sometimes used what's called off-label as fertility preservation. This is a drug called leuprolide, and it basically shuts down the hormone stimulation of the ovary. And by doing that, it prevents the eggs and follicles in the ovary from maturing the way they do every month. And the thought is that by keeping the ovary in a more resting state, that we may be protecting eggs from being damaged by the chemotherapy. The challenge is that the research results on this have been very conflicting. Most of the studies have looked at women with breast cancer and lymphoma, and the feeling is that this should not be considered a standard treatment. It still should be considered investigational because the results do conflict, and it isn't really clear that this is of benefit. There are some other studies being done now, really just in animals, looking at different other drugs that might protect the ovaries, but one of the concerns with these is whether or not these drugs might be also protecting the cancer cells. And so these are in very, very early stages of research with animals only at this point.
Next question is from Tennessee. Young woman with cervix cancer scheduled for radiation and is inquiring about potentially delaying a few weeks to retrieve eggs. Refer to a fertility specialist, and what are the options? And she's worried about endangering herself. In general, I would reassure you that if this is done in a planned way with good coordination between the radiation oncologist, medical oncologist, gynecologist, and the infertility specialist, there is no evidence that there is danger to you in having ovarian stimulation, having your eggs retrieved, and then proceeding with chemoradiation. Most of the cervix cancer patients that we treat who would like to do this can proceed with this. There are a couple of weeks for stimulation, and then eggs are retrieved, and then you can proceed with treatment. So I would encourage you to continue with the plan as long as this is coordinated well with the team that's caring for you.
I am going through, this question's from Danvers, Massachusetts. I am going through treatment now for colon cancer that includes radiation. My doctor said this will most likely impact my ability to have children. My husband and I would consider adoption at some point if my health is good. Will my medical history affect my ability to adopt? So here in the United States, there are no absolute rules about who can and cannot adopt, but everyone's concern, of course, is the well-being of a child, and so they're going to want to be confident that you are well and will be able to raise this child. So the best chance, so definitely adoption is a great option, and many cancer survivors do adopt to build their families after treatment. Generally, it's recommended that you be healthy and disease-free and have completed treatment for at least 3 to 5 years. The other thing that I would recommend you consider is interviewing a number of different reproductive attorneys and adoption agencies to make sure that their attitude is a positive one about your ability to be successful, so that you don't spend time with an agency that is not really trying to support you in this. So different agencies may have different opinions. In terms of international adoption, it may be much more challenging with a cancer history because some cancers specifically forbid adoption to anyone who's ever had a history of cancer. And if you were looking at international adoption, you'd need to really work with an agency or an attorney who's very knowledgeable about the laws of each of the different countries.
This question is, why is removal of the ovaries typically required for low-grade endometrial cancer? Is it absolutely necessary? Very good question. So, in general, low-grade endometrial cancer is usually estrogen receptor positive. In other words, it may potentially be driven or stimulated by estrogen. So traditional teaching has been if there is an endometrial or uterine carcinoma that's potentially driven by estrogen, is to remove the ovaries as well as part of the treatment. The other two sides to the question and the answer is that sometimes uterus cancer can spread to the ovary, so that would be another way to prevent the disease from progression. The third possibility is that there sometimes can be a synchronous cancer. In other words, if you have a young woman with an endometrial cancer, she may also be at increased risk for having a primary cancer arising from the ovary. And also there's a possibility that the cancer may be driven by a genetic syndrome such as Lynch syndrome. So in general, it's whether or not removal of the ovary is to prevent a new cancer, is to be part of the treatment to lower estrogen for a cancer that's potentially driven by estrogen, and also to avoid the possibility of recurrence in the ovaries. Sometimes the ovaries can be preserved with uterus cancer. It has to be studied on case by case.
So this is another question from somebody who's watching tonight. And it's, I've heard that the higher the dose of radiation therapy, the more likely treatment can lead to early menopause. True. And I'd answer this question as it really depends where the radiation is given in terms of the body, in terms of which organ the radiation is being targeted at. But in general, when we give radiation to the pelvis, the ovaries are very sensitive, and the amount of radiation that we use for most pelvic cancers is high enough that the ovary will no longer function. And so that would therefore lead to menopause. And that's why we really advocate transposition of the ovaries for premenopausal women before the treatment of rectal cancer. And it's, we're just gaining a wider experience with it. So in the last few years, we've really increased the number of women we recommend for that. It's a relatively, from my perspective, it's a relatively small procedure. It's done with minimally invasive techniques, and the recovery after it seems to be quite short, and so patients can move on to radiation quite quickly. I don't know, you do the procedure. What do you think about it?
It's a very good procedure. I think pelvic radiation, as Larissa said, in the doses that are usually given for a curative intent, almost always will destroy the ovary. The ovary is very sensitive. It's the most sensitive organ in the pelvis, so it will be destroyed very quickly by radiation. So if you are trying to save the ovary, it should be removed and shielded out of the radiation field, because there is no therapeutic dose of radiation that will not destroy the ovary.
So a question that just came in, does every cancer center have a fertility specialist? So no. Basically, what I would recommend that people do, I think there's increasing awareness among oncology clinicians around the world of the importance of fertility to cancer survivors, and so there's definitely much more awareness of this, but not every center has their own fertility specialist. But you could certainly speak with your oncologist to get a referral to either a reproductive endocrinologist for a woman, or a referral to a reproductive urologist, or to a sperm bank for a man. And if your oncologist is not able to provide a referral, you could find out from your obstetrician or gynecologist. They may be able to be helpful. And there's also a resource on the internet called Fertile Hope. And if you go online and look there, they have something called a referral guide or a resource guide, and you can search for fertility specialists there by state.
So again, it's just the same question. Basically, how do I get a referral to a reproductive endocrinologist? I think you answered it very well. Reproductive endocrinologists are OBGYNs. They're trained in obstetrics and gynecology, and then have a subspecialty in reproductive medicine. So they are available in most cities in the United States. Your OBGYN will be able to guide you. The question in general, is pregnancy safe after pregnancy, is a very broad question. And again, it will depend on the type of tumor, the stage of the tumor, the location of the tumor. So for the question of, in general, is pregnancy safe after cancer, it's best to specifically address that with your oncologist. Many tumors are cured, and pregnancy can be achieved successfully, especially in gynecology. Many of the tumors that we talked about of the cervix or of the ovary can be cured, and then pregnancy can be achieved. But there are some tumors where pregnancy may be a contraindication.
So this question is about the cost of surrogacy. I've frozen embryos, and I'm interested to find out if there are resources available to help with the costs. My doctors have told me that they'd prefer that I use a surrogate because of my medical history, and I did have embryos frozen before my treatment. And I was told by the hospital where I had my embryos frozen that the cost was going to be over $150,000. So I wish I had a better answer for this, but surrogacy is very complicated and is very costly, and there are no specific resources to pay for this. couple of things to keep in mind. One of the things that can influence the cost is whether or not the woman who's carrying the pregnancy, and we use really gestational carriers now who have no biologic relationship to the child, if they have good medical coverage for prenatal care and for delivery, that can significantly reduce the cost, so that's one consideration. There's one organization called the SAM Fund. They provide financial grants to young adult cancer survivors. They have grant applications that go out once a year, and they do have specific grants available for family building. However, these may only be $2,000, $3,000, or $4,000, so they're not going to really come close to covering the full cost, but they certainly can help, not just with surrogacy, but with adoption and IVF and even storage of embryos and sperm.
Well, hopefully we were able to answer some of your questions. I know there may be a lot more questions coming up. We're very glad that you were able to join us this evening, and thank you very much for spending the last hour with us.
Thank you
both.